delighted to open our webinar this morning titled Ecologies of Care, Responding to the Complex Realities of Long COVID. Very excited to be opening our meeting today. We have a 2-hour exciting workshop ahead, and it's our first big symposium for our LAMP study, the Long COVID Assessment and Management in Practice project. So I'm Professor Catherine Itsiopoulos. I'm the Deputy Vice-Chancellor for the STEM College here at RMIT University, and also Chief Investigator on the what we're calling the LAMP project. Before this slide illustrates our breadth of collaborators in this large multidisciplinary project. And towards the end of my introduction, I'll be presenting all of the names of all of our collaborating researchers and partners. So delighted to open the meeting with next slide, please. By firstly acknowledging the people of the Woiwurrung and Boonwurrung language groups of the Eastern Kulin Nation, on whose unceded lands we conduct the business of the university, RMIT University. For those of you that are situated across Australia on other lands, I invite you to also acknowledge the lands on which you're working. We have 200 people, more than 200, that are registered with us today, so delighted to welcome you. I'd also respectfully acknowledge their ancestors and elders past, present and emerging, and any First Nations persons that are with us today or are with us on the journey of this exciting project. And I also acknowledge the traditional custodians of their ancestors and lands and waters and air across Australia, where we conduct our business at RMIT. So a very warm welcome. I'd like to now cross over to Sam Hartman to do an acknowledgement of lived experience, which is a practice that we are very committed to with our LAMP project. So over to you, Sam.
Thank you, Catherine. I would like to acknowledge and honour all those here today who've been impacted by long COVID. I recognise your suffering, your resilience, and your unique journeys, each one unique and deeply personal. I acknowledge the carers, the families and the loved ones whose lives have been profoundly changed while supporting those affected. We take a moment too to acknowledge those who are not able to be here today due to the ongoing effects and limitations of this debilitating disease. I want to extend the acknowledgement and respect to the ME/CFS community who have endured a similar struggles for decades before long COVID emerged. Their advocacy, their knowledge and perseverance have paved the way for greater understanding, and I hope that together we can give back to their community as we move forward towards answers and solutions. Long COVID can diminish our energy and cognition in profound ways. So on behalf of the long COVID community, I thank each and every one of you for the energy, the insight and the dedication you bring to this conference. Thank you.
Samantha, thank you so much. The acknowledgement of lived experience is so important for us to be reminded of the reason for a multidisciplinary project like ours, why we're here, because we want to go beyond the traditional clinical approach to this very complex condition. This slide illustrates where we started, what led us to the current project, and the success that we're experiencing in receiving funding to launch this project. So I'll go through this in a moment. But before we move on, I just wanted to address the audience. We have a mixed audience of researchers, multidisciplinary researchers from different fields, partners that are engaged with us in this project, and people with lived experience of long COVID that have joined us today. The information that we'll share today are insights on the project and what we have, what we've come across, I guess, what we've experienced in our research over the last 12 months and preceding projects, and some insights from our connections with health services, which is the second arm of the project. We won't be providing individual advice on long COVID. And what I'd like to do is for those in the audience that do need any support, that to contact your general practitioner or your healthcare provider for information. We do have general advice on our website, but we're not in a position to provide clinical or health information. I'd also like to highlight that Emerge Australia is a very good place for long COVID information. What we help to build with this project is that information to guide individuals for access to healthcare that they might not have otherwise been able to have. Hence the reason, the very good reason for why we're all together to help move forward this very complex series of health matters that impact those experiencing symptoms of long COVID. So let me start at number one. The project emerged from our network of Eat, Move, Heal network. Now, the Eat, Move, Heal network was auspiced and seed funded by distinguished Professor Magdalena Plebanski, who is the director of the Enabling Impact Platform, Biomedical and Health Innovation here at RMIT. And together with Professor Magdalena Plebanski, Professor Jin Zheng, who's with us today and will be presenting shortly, and myself, and a network, a very large network of researchers, educators, healthcare practitioners from over 10 disciplines, including industry partners and people with lived experience of long COVID, have established this network, and this project has emerged from that network, and that network is doing lots of other things as well. So I'm delighted to be part of that network, and delighted that this network has also led to projects that have provided the background to the long COVID assessment and management in practice project that we're presenting today. The Eat, Move, Heal, if you think about those different components, refers to lifestyle and evidence-based interventions of diet and nutrition, physical activity and movement, and mental health modulation, hence that acronym. And I think Professor Magdalena Plebanski was responsible for that, which is a great acronym or series of words that illustrate the breadth of focus of the different elements of care. We then move on to phase two, which is, or step two, the pilot work that preceded the LAMP project, the journey mapping of patient experience. And there's a graph there, which is a sophisticated capture of in-depth interviews with video capture of people with experience of long COVID. And that work was led by Professor Bernardo Figueiredo, and that was published. So thank you, Bernardo, for leading us in that work. And there were researchers Jun and Rose Luo and Jacob Sheehan, who are with us today, who collaborated as well as many others in that work. We also, led by Rose Luo and Jun, reviewed long COVID policies and services and published that work, and there's updates of that work in publication train as we speak. And what that work has done is identified the need for transdisciplinary consumer-led models of care for people living with long COVID, and a better understanding of the diverse impacts of long COVID across different groups, culturally and linguistic diverse groups, children, Indigenous communities. And hence we then developed this grant, which is a multidisciplinary across, for RMIT, across all of our colleges, I'm proud to say. A way I describe it to my leadership here at RMIT and to the outside world is that we have taken a traditionally biomedical immunological condition, post-viral complications of long COVID, and explored this series of complicated conditions with social scientists and people from marketing, and it is truly transdisciplinary. And consumer-led, which is core to the work that we do, and I think that's been instrumental in the success of achieving the funding from MRFF for the project, which is titled "Emerging from the Long Shadow: Optimising Supportive Consumer and Provider Care Pathways Through the Post-Acute Sequelae or PASC of COVID-19." So we move to the next slide, please. And on this slide, I'll provide an overview of what the LAMP project, again, I think distinguished Professor Magdalena Plebanski has also provided us with a lovely acronym, LAMP, which signifies lamp, light, way forward. So what the LAMP project does is addresses, or is doing, addressing the need for a consumer-led integrative model of care for people affected by long COVID, with three key phases, or three key missions, if you like. Developing a meaningful understanding of long COVID across diverse populations in Australia. So capturing those diverse populations is key. Informing a transdisciplinary consumer-led model or models of care, and that is working with different healthcare services and supporting a coordinated approach to Australian research. Throughout this approach, this experience-based co-design is core to our methodology. We received $5 million from MRFF, and the grant is over the next 5 years, and we are approaching the end of that first year. An extensive group of partners, which were depicted on that first slide that you saw today: Northern Health, Victorian Virtual Emergency Care Department, Hands On Health, the Australian POTS Foundation, Carers NT, the University of Leeds in the UK, Adelaide University, Charles Sturt University. So a broad network of partners, which are core to the success of this grant. Next slide, please. This slide is an illustration of those three different parts and how we're going to answer those three different phases or missions or priorities. And we are currently here, as the slide shows, in Arm 1, gathering consumer experience with PASC, post-acute sequelae of long COVID. This is mixed methods approach. We've completed the qualitative exploration or in-depth interviews with about 40 different participants across different consumer groups, and we're just about to launch an extensive cross-sectional survey, cross-sectional and longitudinal prospective survey to an audience of about 1,000 participants. Using a validated PROMS tool, which is derived from the YRS C19 tool developed by our collaborator from University of Leeds, Manoj Sivan, and many other components to that tool. So we're just about, we are here. Today's Ecologies of Care session involves clinicians, so exploring service factors. We are getting ready for Arm 2, and this is really, today is our transition into Arm 2. We have built a network of clinician advisors, and I'll illustrate the different members of that group in the final slide. But better understanding the service factors is what we aim to do in Arm 2. And then Arm 3 is co-design and evaluation in practice and policy, and that is building the models of care that better address the gaps that we see in caring for people that experience symptoms of long COVID. Next slide, please. So this is why Ecologies of Care, and what do we mean by this? Long COVID impacts individuals in a holistic way. It isn't, as I've addressed earlier, just a clinical problem, a series of symptoms that have emerged following a viral infection, such as COVID-19. And what we see is that that long COVID challenges the conventional ideas of illness, recovery, and healthcare. And people that experience symptoms of long COVID have to navigate multiple fragmented systems across health, across their work, welfare systems, their family and community, to try to access care and support, yet they fall through the cracks. And this is something that we are discovering in our phase one, in all of our connection with people that have experienced long COVID through our qualitative studies, and now as we move into our quantitative surveys. It's very important that we focus on rationality in order to better understand long COVID. What this requires is attention to how all these systems interact rather than viewing them in silos and purely clinical. This approach emphasises the relationships, the environments and resources that sustain well-being. Why does this matter? It reveals where care breaks down or can flourish across systems. So seeing care as an ecosystem reminds us that it's not just about medical treatment, but how different forms are there to help connect or fail to connect. So our discovery through the different arms, and particularly arm 2, where we are exploring health services and how they support, or otherwise where there's lack of support of people suffering long COVID, identifying those gaps is critically important for us to be able to build and a model of care that is holistic, that tackles all of the elements that individuals experience, and how we can better meet the healthcare needs of people that experience long COVID in that all joined up and holistic way. Next slide, please. As promised, this is the extensive team, the LAMP research team, and the critical advisory groups on the right. So on the left, we see an extensive list of 20 chief investigators, associate investigators that represent a broad multidisciplinary group across 10 different disciplines, and organisations that are core to us being able to access the participant population, and also the tools needed to explore this very complex series of health conditions. We've also got a contracted project team, and our MC today, Dr. Emma Seal, will be joining us shortly to MC the rest of the meeting, and all our researchers are listed there. You will see them on screen as they present the different parts of today's session, and we also have guests, and we'll be presenting, introducing those in due course. To support our research, we've set up, so we've got the investigator and project team that meet very regularly. We've got the lived experience advisory network, and we've heard from Sam already, who's part of our lean members. The ethos or the methodology that's core to our design is experience-based co-design. So engaging members with lived experience is core. Otherwise, we would not be able to really deliver on our promise. The clinical advisory group is an extensive group of healthcare providers who have deep experience with long COVID. So they are instrumental to our success in this project. Next slide, please. So my final slide is just to illustrate what our format is today. We've got presentations on Health Economics and the Broader Healthcare System for Long COVID, presented by Danny Hitch, who's about to join us on screen from Deakin University, followed by Long COVID Care in Australia, 2025, What's Changed, What's Missing, presented by our Dr. Rose Luo from our LAMP team, RMIT University. Invisible Care is the next presentation, exploring informal caregiving and long COVID, presented by Natalie Jovanovski from our core LAMP team, RMIT University. And then how do we take our learnings to inform health practitioner education, presented by Professor Sonia Cleary from our investigator team, the LAMP project, and also part of our lived experience advisory team. And then we've got a Q&A panel discussion, which is an opportunity for a Q&A session and questions from the audience. Please, as you're hearing from all of us today, include your questions and we will filter them through to the panel. Very excited to join all speakers today, hearing from our audience as well. And without further ado, I'd like to hand over to our MC, Emma Louise Seal, to take us to the next presentations. Very warm welcome to everyone. Looking forward to very exciting 2 hours ahead of us. Thank you. Over to you, Emma.
Thank you so much, Catherine. I'm not sure, I hope everyone can see me if I've come up on screen. But I'm here just to sort of hand over to Danny, who's going to be kicking us off today, looking at health economics and the broader healthcare system for long COVID. So I'll just be popping up in between each presentation just to keep things flowing along. So over to you, Danny. Thank you.
Thank you very much. That was a great introduction to what I think is going to be a really great day. So my name's Associate Professor Danielle, you can call me Danny Hitch, and I'm in a joint position with Deakin and Western Health. And just wanted to extend my gratitude for being invited as a guest speaker today. Next slide. So this presentation draws on our recent book chapter, which was called Health Economics and the Broader Healthcare System for Long COVID. And that was co-authored by Mary Rose Angeles, who you can see on the slide, Karen Dickinson, who's our lived experience expert, and Professor Martin Henscher from University of Tasmania. I'd particularly like to acknowledge the contribution of Mary Rose, who's my co-presenter, even though she can't be here today. Our aim in that chapter and in this presentation is to situate long COVID not just as a clinical or rehabilitation issue, but also as an economic and systems challenge that shapes how care is organised, funded and accessed. In the next 10 minutes, I'll review the major economic dimensions of long COVID, its impact on quality of life, productivity, health service use, healthcare costs, and the broader barriers that people face in navigating care. And I should also have said at the start, I'm also an occupational therapist, so I'm also a clinician. Next slide, please. So from an economic standpoint, long COVID generates costs at multiple levels, the personal level, the health system level, and the societal level. At the individual level, people experience major losses in participation, health-related quality of life, and their income. At the systems level, long COVID increases demand across already very stretched healthcare sectors in primary care, hospitals, community rehabilitation, pretty much every corner of the health system. And at the national level, it reduces labour force participation and productivity, and that has a measurable impact on GDP, which I'll talk about in a moment. So economists describe this as a triple burden. It's lost well-being, lost productivity, and increased expenditure, all happening at the same time. So these intersect to create a new form of pressure on health systems globally, so it's not just an Australian issue, obviously, which is also linked to the rise in chronic conditions more generally. Next slide, please. So international studies and our synthesis that's in the book chapter show that people with long COVID have health-related quality of life scores on the EQ5D, which is a very commonly used tool, and they score between 0.49 and 0.64. So to put that into context, that's lower than average scores for diabetes, chronic lung disease, heart failure, multiple sclerosis, and end-stage renal disease. And it's also similar scores to what's seen in people with advanced cancer. Functionally, The Work and Social Adjustment Scale scores average for people with long COVID around 19 to 21. So this indicates really marked impairment in daily life and participation. So the profound impact on function and participation for people with long COVID was also confirmed in research completed by my group in an Australian cohort, and that used the WHODAS, the World Health Organization Disability Assessment Schedule. And that also confirmed its impact is equivalent to ME/CFS, stroke, rheumatoid arthritis, and Parkinson's disease. So that gives you a bit of an idea of the magnitude of the impact. Even 12 months after COVID infection, the average recovery is only 89%. So this is an average. So that's an overall health loss of roughly 11% and 10% reductions in working capacity. These figures underline that long COVID isn't just a lingering fatigue, it's a substantial reduction in human capability and well-being, and it causes major loss in quality adjusted life years. So quality adjusted life years are just a way of measuring both how long someone lives and how well someone is living. Next slide, please. The labour market effects of long COVID are very striking as well. In the study summarised in the chapter, about 58% of people with long COVID required sick leave, and about 3/4 had absenteeism 6 months after their infection. 45% returned to work on reduced hours, and between 7 and 52% experienced repeated employment disruptions. Depending on the cohort, 2 to 23% had not returned to work at all within 12 months. So the variation in estimates is due to how the outcomes are measured in different studies, but it also makes it very difficult to compare the evidence between different studies. Having said that, it consistently shows there's a huge impact on workforce participation. Next slide. So at the macro level, the cumulative impact is also very substantial. When it's scaled to national populations, even small percentages translate into thousands of full-time equivalent workers lost. The macroeconomic modelling in our book chapter estimates that multi-billion-dollar productivity losses occur every year. And that affects not only the wages of individuals, but also tax revenues, superannuation and household spending. So it contributes to broader pressures in the economy. So drawing together international modelling, it showed that national GDP losses ranged from between 0.5 and 2% annually due to long COVID. And that's related to labour shortages and healthcare expenditures. Now 2% may not sound like a lot, but in Australia this equates to several $billion per year. So it's billion with a B, compared to the annual costs, comparable to the annual costs of chronic kidney disease. Next slide, please. So economically, long COVID does behave like other chronic multi-system conditions in that it drives persistent and elevated healthcare use. Across the 6-month follow-ups that we have reported, people diagnosed with long COVID use significantly more primary care, telehealth, urgent care, inpatient and outpatient services than matched controls. Utilisation seems to peak at 2 to 3 months post-diagnosis and then declines slightly, but it still remains well above the baseline. Healthcare costs are roughly 40% higher than for people without long COVID, and depending on the study design, total healthcare expenditure rises between 1.3 and 2.9 fold in the 6 months after diagnosis and remains elevated for much, much longer. So from a systems perspective, this sustained demand places pressure on hospital budgets, workforce planning and rehabilitation capacity, particularly in public funded systems like Australia, and I would say particularly in disadvantaged communities like the Western Melbourne community that I live and work in. It underscores why integrated and community-based models of care are critical for both economic sustainability and equitable access. Next slide, please. Beyond the numbers, this all reflects real human stories. People unable to sustain their professions, families adjusting to single incomes, and communities losing skilled workers. Financial and logistical barriers compound these costs. So people with long COVID often face out-of-pocket expenses for medications, allied health sessions, and private consultations not covered by public funding. Deferred or delayed care is common when people cannot afford fees or transport. Our lived experience co-author, Karen Dickinson, described how the cost of attending repeated appointments, coupled with energy limitations, forced her to choose between treatments and daily necessities. These trade-offs are both economically inefficient and ethically not okay. They shift the costs from the system onto already unwell people. Equity, therefore, is a really central economic concern. If access depends on your capacity to pay, the burden of long COVID always disproportionately falls on low-income and marginalised populations, and that deepens existing health inequalities in the Australian community. Next slide. And importantly, these are all avoidable losses. Economic modelling shows that timely rehabilitation, workplace accommodations and primary care support have high returns on investment by restoring functional capacity and preventing secondary complications. The interventions on the slide have all demonstrated effectiveness in reducing symptoms and functional disability, and importantly, they are cost effective. However, they're not widely used in Australia. So the policy responses really should focus on investing on accessible rehabilitation services, embedding long COVID within chronic disease funding streams, and recognising lived experience expertise as an essential part of designing cost-effective models of care. In other words, economic sustainability and health equity are not competing goals. They are interdependent. When people with long COVID can access appropriate early support, both well-being and productivity improves. Last slide. So to summarise, long COVID causes significant health-related quality of life loss, comparable to severe chronic disease. It produces measurable productivity losses through absenteeism, reduced hours, and job loss and career loss. It drives sustained increases in healthcare utilisation and expenditure across all sectors of the health system, and it exposes systemic inequities in access, particularly where out-of-pocket costs or fragmented services exist. So in summary, from a healthcare economics perspective, investing in long COVID rehabilitation is not a cost, it's a form of investment and economic recovery. The sooner we treat and support people effectively, the greater the return in restored participation, reduced healthcare use and personal quality of life. Given the society-wide impact of long COVID, proactive assessment, treatment and supports for people with long COVID is good for everyone and is therefore everyone's business. Thank you.
Thank you so much, Danny. That was fantastic, and I think very clear evidence to inform the work in the space and policy making in this space as well. So really appreciate your insights around that, and thank you. Just a quick note for everyone as well that we are recording today, and we'll share that afterwards as well and make that available to people. I'd just like to hand over now to Rose, who's going to take us through the next presentation. Over to you, Rose.
Thank you, Emma. Good morning, everyone, and thank you for joining. My name is Rose Law. I'm a research fellow working on the quantitative aspect of our LAMP project. As a background, I'm also a registered nurse and a Chinese medicine practitioner. So in the next 10 minutes, I will talk about long COVID care in Australia 2025. Next slide, please. I'd like to start with some background information. So in 2023, when our understanding of long COVID was still emerging, we wanted to know what the guidelines recommended and what long COVID specific services look like in Australia. So we conducted and published a review that summarized recommendations from long COVID guidelines, mapped long COVID support services in Australia, identified gaps between guideline recommendations and existing services, and proposed care model for future health programs. Next slide, please. In 2024, the Australian government released the National PASC Plan. The plan provides a national framework to guide Australia's health system response to long COVID and outlines a few strategic priorities, including improving primary care-based models with wraparound multidisciplinary support to deliver patient-centered care, using existing health reforms to address long-standing barriers, improving awareness and understanding of long COVID among healthcare providers and broader community, and supporting self-management and embedding principles from the National Strategic Framework for Chronic Conditions in Long COVID Management. Next slide, please. Recently, we completed an updated review of long COVID guidelines and services. So in today's talk, I will focus on two main areas. First, I will provide an update on long COVID guidelines since our 2023 review. Then I will go through and highlight the trends and changes in services delivering long COVID care across Australia. Next slide, please. Before we look into the guidelines, let's have a look at the definition of long COVID used across all guidelines. The majority of the guidelines use the WHO definition, which defines long COVID as ongoing or new symptoms 3 months after the initial COVID-19 infection, with these symptoms lasting for at least 2 months with no other explanation. The US CDC definition is slightly different. It adopts the definition from the National Academies of Sciences, Engineering and Medicine, which describes long COVID as a chronic condition that happens after COVID-19 infection and is present for at least 3 months. This definition does not require a formal diagnosis of initial COVID infection, so suspected COVID-19 is supported. It also does not include a statement about exclusion of alternative diagnosis. This means it supports pre-existing conditions such as ME/CFS and POTS as part of the broader picture of long COVID. Next slide, please. Now, let's have a look at the recent changes in long COVID guidelines. So since our 2023 review, the WHO UK and New Zealand long COVID guidelines remain unchanged. So their recommendations all emphasize the importance of holistic and multidisciplinary care, person-centered care and shared decision-making, guided self-management and patient education. The US CDC, however, has revised its guideline, for example, changing the definition of long COVID. So the duration of symptom changed from persisting for at least 4 weeks after the acute phase to at least 3 months after infection. It now provides a clear public approach to long COVID and acknowledges the broader impacts on daily functioning, the workforce, and children with long COVID. Next slide, please. We also found 2 new guidelines. One is the Canadian guideline, which recommends integrated and multidisciplinary care, hybrid service delivery, self-management, healthcare workforce training, patient and public education. It is the only guideline that provided some practical advice on implementation of its recommendations. Next slide, please. The other new guideline is the New South Wales Agency for Clinical Innovation guideline. I'll expand on this in the next slide. So meanwhile, the RACGP guideline that we included in 2023 is no longer available. In addition, NHMRC is leading the development of Australia's clinical practice guideline for ME/CFS, which will also reference related conditions, including long COVID. They will be released at the end of 2027. Next slide, please. So the New South Wales ACI guideline is consistent with other guidelines, which stresses the importance of patient-centered and multidisciplinary care. What makes it different is that it promotes value-based care. Value-based care is defined as the equitable, sustainable, and transparent use of available resources to achieve better outcomes and experiences for every person at all stages of their health journey. It also encourages the use of existing health services and discourages unnecessary diagnostic procedures and overtreatment. Next slide, please. Now let's look at the trends in long COVID services in Australia. A total of 20 active long COVID services have been identified across Australia, with a significant proportion being private clinics. Among the active services, there are 6 public clinics and 14 private ones. Next slide, please. There has been a marked shift towards transitioning long COVID specific clinics into existing chronic disease services. 7 hospital-based outpatient clinics that we identified in our 2023 review have now closed for dedicated long COVID care. However, all of them have been absorbed into relevant specialist care, rehabilitation services, or chronic disease management programs, continue to provide long COVID care alongside other conditions. Next slide, please. So public services are generally bulk billed, but require GP referral, which nowadays often involves a gap fee. Private primary care-led services are usually self-funded, but may accept Medicare rebates, private insurance, and in some cases, NDIS or work cover. These services are usually multidisciplinary, led by specialists or GPs, and involving nurses and allied health professionals such as psychologists, occupational therapists, physiotherapists, exercise physiologists, dietitians, and speech pathologists, and so on. Most services offer hybrid delivery, providing both face-to-face telehealth appointments, so care is easier to reach. Next slide, please. Now, let's have a look at the guideline and service gaps. So recent guidelines emphasize integrated, multidisciplinary, and primary care-led approaches. This is partially reflecting Australia's recent shift from hospital-based to primary care-led clinics. However, there are some gaps identified, which has been mentioned by Danny's talk as well. So first of all, the services are fragmented. There's a lack of coordination and system-level integration across Australia. There are also some gaps in guideline dissemination and no clear implementation plan. The responsibility for long COVID care has largely shifted to primary care, but this hasn't been matched with enough support, such as a clinical toolkit or clear referral pathways. And for many people, cost is a real barrier. Most services operate on a fee-for-service models, creating substantial out-of-pocket costs, especially for the people whose work capacity is already reduced. Together, these gaps highlight what's still missing in Australia's long COVID care landscape. And that brings me to the end of my talk today. And you can find the references in the next slide. And the final slide is thank you.
Thank you so much, Rose, for that really clear overview of what's sort of happening within the Australian context at the moment. Yeah, really good to understand sort of policies, guidelines, and practice collectively. So thank you for that. We originally had a Menti for this as a sort of short interlude in between each presentation, but in the interest of time and to make sure we've got enough time at the end for Q&A, as we mentioned, if there are questions sort of bubbling away that you'd like to ask, please shoot them through. We'll do our best to answer them as part of the Q&A at the end. But what we'll do is move on now straight to Nat to present on invisible care and the experiences of carers. So over to you, Nat.
Thank you so much, Emma. Good morning, everyone. My name is Dr. Natalie Jovanovski, and I'm a Vice-Chancellor Senior Research Fellow here at RMIT, and I'm also a Chief Investigator on the LAMP project. My qualitative colleagues are Dr. Kate Anderson, Dr. Jacob Sheehan, and Dr. Emma Seal. So today I'll be talking a little bit about the often invisible experiences of informal carers, or people who provide emotional and instrumental care to those living with long COVID. Now, I note that most informal care is actually invisible, but there's something doubly invisible about the experiences of this group of people that we will talk about today. Before we officially launch into the presentation, though, I just want to note that the term carer is a contested label. Some of our participants had no problem referring to themselves as carers, while others struggled to reconcile their own identities with their newfound carer role. So when I'm talking about carers today, I'm not talking about one group of people who all believe the same thing. I'm talking about a group of people, some of whom are actually grappling with the label of carer. Next slide, please. While those who provide informal care to people living with long COVID play a really important role in the broad ecosystem of care, research on this group of people is actually very scarce. So most of the research we could find on carers focused on caring for people during their COVID infection rather than for those whose symptoms have persisted. There is, however, a more established body of literature on informal caregiving for people with conditions that share similar features to long COVID, such as ME/CFS. And some of this literature has pointed to their invisible labour, their social invalidation, the economic strain they experience, and the value of peer support for people who do provide this informal care. Next slide. Now, we believe that informal carers may reveal important insights into long COVID management and the type of care that people living with the condition both need and currently receive. So we set out to speak to people who provide informal support to those living with long COVID, including people who are currently living with the condition, as well as those living with conditions that share similar features to long COVID. And we asked, how does long COVID shape caregiving? And what do the experiences of informal caregivers say about how care is negotiated in relation to long COVID? Next slide, please. We conducted 10 in-depth interviews with informal carers, and we shared our flyers in relevant social media communities, as well as through snowball sampling. We're currently in the process of conducting a thematic analysis of this data, and as you can imagine, it's quite a big body of data. We've got 40 interviews to look at in total. So the findings we're sharing with you today are some of our preliminary ones. Our participants, as you can see on the right, were quite a diverse group of people. I think most notably here is that participants cared for their children, both young and adult, and they cared for their partners, new partners, and married couples, long married couples, as well as parents. And care ranged from between 6 months to 5 years. Next slide. One of our first preliminary findings was that, like other informal carers, those caring for someone with long COVID often engaged in very intensive caregiving. For many, it was virtually impossible to switch off their caregiving role or to have some space from it. So these are some examples of some of the quotes that we receive from carers. The first one says, "I have my phone on my chest, my mobile, and I'm sleeping in full clothes with shoes on, ready to go." And in this case, it was ready to take their loved one to the hospital for care in case they needed it. In the second quote, our participant said, "It's really changed our dynamics. I mean, she, her daughter, is 23 years old, just starting to head off out into the world on her own, and then she's come back into this space. I try to be caring and patient, but there are days where she can't do anything. Showering is like an old lady. Sometimes she can go a week, if not longer, not even being able to face that. I wash her hair for her. I cook for her. I shop for her. I often wonder what on earth she would do or how she would survive if she didn't have me. In some ways, it's lucky she was with me because I don't think she could have been in a share house and needed that level of help that she does with friends. I know that if she was on her own at that point in time, she wouldn't have survived." So this shows how significantly a lot of that instrumental care features in carers' lives. Next slide. Some participants talked about the invisibility of their care work and the added political dimension that often prevented people from empathising with them. Quite often they compared their caregiving with people who care for a loved one with cancer, which some described as a more concrete and socially accepted condition. The second quote that we have here is actually from a participant who had previously cared for a previous partner with cancer, who unfortunately passed away, and is now caring for their new partner with long COVID. And they said, "The support for cancer patients is significantly better than for long COVID because it seems to be recognised." Well, it is a recognised condition, whereas long COVID people seem to have heard Whereas long COVID, people seem to have heard of it now, but I don't think there's a lot of understanding about what it is and what the impact is. And the first quote says, she, my daughter, often says, I wish I had terminal cancer. A, people would be more empathetic and understanding, and B, there would be an end to it. That's just robbed her of her life. It's robbed me of mine. We're getting there, but I would like to see more support. Next slide, please. Carers often relied on informal support to wade through significant chunks of information. They often turned to trusted members of their family who also happened to have a lived experience with a chronic invisible condition. In this particular example, it was the grandmother in the family. So we often send things to grandmother and she'll kind of be the filter. She loves to kind of deep dive on everything, and it's great to have that. It's great to have grandmother as the filter. That can be like, this is actually legitimate, this isn't legitimate, this is ridiculous. Because we don't always have the time and energy kind of in the trenches with our kids, you know. It's so busy. To have grandma's help is a huge blessing. So as you can see, a lot of that informal caregiving is also coming from members of the family who are also living with invisible chronic conditions. Next slide. Participants also talked about being anxious and overwhelmed about the formal support they were receiving or trying to get a hold of. Some complained about the bureaucratic hoop jumping that they struggled to get on top of. So as you can see, the first participant says, I think it took 2 years to get to the point where my daughter had done enough investigation to even begin to go onto a disability pension. That was thousands of dollars in medical tests, medications, and of course, because she wasn't working and she was, I suppose, lucky in a way that she had a doctor who was prepared to give her Centrelink, I don't know what it's called, waiver, so she didn't have to look for work because, of course, she couldn't work. If she could, she wouldn't have needed Centrelink. For some, there were particular fears and anxieties that government interest or government care about this topic would dry up. So one participant said, I mean, even more cover for Medicare is needed because this is important. And it's just like, just the fear that the funding might dry up for that or that people will stop caring. So for this particular participant, there was fears that broader institutions and structures would stop caring about this condition, making their lives and their loved ones' lives much harder. Next slide, please. Okay, so how are we making sense of this? Well, one of the ways that we're approaching the experiences of carers is through the concepts of caringscapes and carescapes. So caringscapes are informal caring journeys that are often characterised by love, social obligation, and other features. So pretty much those that I shared with you today in our excerpts. But we're also focusing on carescapes, which are the contexts where individuals provide that informal care. Quite often, this context is mediated by policies, services, and infrastructures related to care that are determined by government, employers, etc. And so as a group, we're particularly interested in the interactions between the individual's informal caregiving and the structural and institutional contexts that shape how they are able to best provide care. And this is because we acknowledge that care doesn't occur in a vacuum, and we need to acknowledge the broader ecologies of care that support those living with long COVID. Next slide, please. As I mentioned earlier, we are still in the very early days of analysing this big body of data, but if you have any questions for us about our analysis, please contact us on longcovid.project@rmit.edu.au. Thanks very much.
Thanks so much, Nat. You know, we don't often hear about the experiences of carers and supporters of people living with long COVID. And so I think moving forward, if we're thinking about responses, then we need to be thinking about the needs of carers as well. So really appreciate that. Without much further ado, just passing on now to Sonia, who's going to be last cab off the rank, but last but not least this morning in our presentations, to take things away for our final one. Thank you, Sonia.
Thank you. And thank you for listening. I am somebody who experienced long COVID. My background as a health practitioner is as a registered nurse, and I've been involved in health care education for health practitioners across RMIT and previous to that, Central Queensland University. So I have a deep inviting passion on how do we take what we're learning here, and this is quite amazing being a participant in this and a researcher in this project. But how do we take what we're learning to inform our health practitioner education? So that's a bit of a provocation for some of you in the audience, and we need to be thinking about that into the future, because we've heard from other members today of the lived experience and the challenges that carers face, the economic challenges in relation to recovering from long COVID. But how do we then translate that to training our future healthcare professionals or the existing ones? Next slide, please. So one of the things that I was looking at, some of the qualitative data in our lived experience participants, is very much about when they're going to their health practitioner, they're accepting that the health practitioner doesn't know everything, and it's okay that they don't know. And something that I felt very early on when I had it, and as a registered nurse, I was at the coalface, so I got long COVID pretty early, even though I was fully vaccinated, and then I got long COVID. But that trying to understand what people know, and at that point people didn't know, practitioners didn't know. So, but this ability to express that vulnerability. It's okay that we don't know at this particular point in time. The other really important thing, which comes from the wording of our participants, is that, you know, they're really expecting their practitioners to be non-judgmental or really non-judgmental. Other information came through around the carers of children with long COVID. You know, this preconceived misconception that children don't get long COVID or don't have long COVID, and therefore why are you coming, and are you coming because you're making your child ill? Sort of almost Munchausen by proxy perspective, which is very biased, is driving people away from accessing health service. There's a need to understand the complexity of the subconditions under long COVID, or the long COVID umbrella. And from a particular, another lived experience view is, if I went to a normal GP, if I did go to a normal GP and I would tell them what I was experiencing, somebody who didn't understand the full umbrella of the long COVID sequelae, then you know, they're seen as a complete hypochondriac. Next slide. So we need to think about how we're training our healthcare practitioners for any of these areas. So recognition and empathy, so validating patient symptoms, challenging stigma, listening actively. Patient-centeredness, we always talk about that in our healthcare services, but do we really do it? You know, and we need to be thinking about how that works. And I think somebody earlier talked about value-based care. So that's another one that we should be putting into our thinking as we're training our future healthcare professionals. Understanding, you know, what is in the background. So, you know, POTS and MCAS and chronic fatigue, inflammation, other viral issues. We need to understand the complexity of this particular the things that these particular patients and participants are experiencing. Collaborative practice, that's coming through clear everywhere. It's like referral pathways, and do they work? Allied to primary health and backwards. Are they working? How are they working? Can we make them work more effectively? And what is the role of the future health professionals in ensuring that? Addressing access barriers, so advocacy for NDIS, PBS, cost awareness, system navigation again. Scientific literacy, critical appraisal, honest communication about uncertainty. We saw that when somebody said it's okay that doctors don't know everything. We don't expect them to know, but critical appraisal and communication skills. Next slide. So how do we embed this? This is a big challenge, and, you know, health practitioner education is, you know, sometimes between 3 and 6 or 7 years, and everybody wants to put everything in the curriculum, and they want it now, and they want it done, and they want everybody to come out fully emerged, but we know that that doesn't occur. So how do we embed this? A provocation that I've thought, or thinking about how we do this, is thinking about this research that we're currently involved in. There's enormous amounts of data and information about the lived experience. How do we gather that all up into an AI-supported simulation case scenario? When I say AI-supported, our mannequins now can be AI and they can talk, which is fantastic, or virtual reality of AI can be also understanding some of the lived notions and learn on that, and then thinking about reflective practice and debrief. So I want to encourage, as part of this project, is thinking about what we're doing and how does this translate, and all your knowledge and feedback and wisdom over this process. And it's not only at RMIT, this could be across many health universities that train health professionals. So thank you.
Thank you so much, Sonia. Really important insights, sort of bringing that together in terms of, well, we know potentially where the challenges are and how do we take that forward in terms of health practitioner education, and where do we embed that, and what does that look like? Now that's the end of our presentations. There's a sort of, before we kind of move on to the Q&A, we thought we might give everyone a little bit of a sort of a break. And so there's a short Menti here, a short provocation sort of following on from Sonia's presentation, if you'd like to engage and interact in that. So you can go to menti.com and pop in this code, or use the QR scanner there to bring up the question. And then if you'd like to answer, you can, but we might give everyone a couple of minutes just to sort of take a bit of a break, and then we'll come back together in a couple of minutes and we'll start the Q&A. So if you've got questions, start popping them through, but we'll just give everyone a minute or two, and then we'll start the panel discussion, and I'll jump back on when we do that. That was a quick couple of minutes. Thanks to those that are sort of answering. You can continue to answer. So even when the slide sort of disappears, if you're in Menti, then you can kind of continue to add your responses if you wish to. So now for the final part of today's webinar, we're just moving on to our panel discussion. So this is going to be moderated by Chen Cheng. We've got Laura, Sam, Danny, David, and Jacob that will be in the hot seat today. So we'll start off with a few kind of questions that we'll pose to everyone on the panel to sort of, I guess, spark some debates around some of the things that we've heard, and how do we take this forward. And then kind of at the end, there's an opportunity to feed questions in from the audience. So if you've got questions that are, that you're thinking about or you'd like to pose to anyone on the panel, then pop those through, and then Nat and I will be sharing those from our end for the panel to answer. So if you want to join us, guys, and then I might leave it to Chen to take it away for us. Thank you.
Thank you, Emma. So good morning. Thank you everyone for being here. You're here because of your care. So what a morning we had, and we have these amazing speeches talk about about the impact of long COVID, the fragmented service, and the invisible care, and the education we need to consider. Now, in this session, we will turn our focus to care. So our panelists going to discuss what is care and what types of care that people living with long COVID would like to have or already experiencing. So we're fortunate to have a panel with diverse expertise and perspectives. So could I please let our panel turn on their camera and the microphone? So I see Daniel there, Sam, that's great. Terrific, thank you. Have we all the panels here? Is David here?
Yep.
Great. And Laura? Is Laura
Yeah, I'm
too?
here.
Great, thank you. That's lovely. So maybe I will start with you each introduce yourself. How about we start with Sam Hartman?
Yes, thank you. So you've already met me. I did the acknowledgement at the beginning. My name's Sam. I've been a long COVID sufferer for 3 years. My previous life, I was a registered nurse and a lecturer for enrolled nursing here in South Australia. And then one day my life changed dramatically when I went from a very fit and healthy woman running a busy household with young children to spending the next 18 months in bed. And since then, I've been slowly clawing my way back out of the house slowly with lots of setbacks. And yeah, so very happy to be here today.
Thank you, Sam. Next one. How about Laura?
Yeah, hi everyone. My name's Laura Allen. I'm the Health and Support Manager at Emerge Australia. My background's nursing, and I started my role primarily looking at ME/CFS pre-pandemic in around 2018 as a registered nurse, doing just a little project based on what it would look like to have a nurse in the not-for-profit sector supporting patients.
Yes, thank you, Laura. So you come here representing Emerge Australia.
Yeah, yeah.
Yep. Sam's here. Sam is actually one of our lean member representing consumers on our research project. Next one. How about Danny?
Hi everyone, you saw me before. So I've been an occupational therapist for over 25 years now. And through my career, I worked with people with lots of different conditions, but I also worked in the ME/CFS clinic for a little while when I was in the UK. And as I mentioned before, I'm a health economist, so I'm wearing 2 hats.
Yes, indeed. Your new book is very inspiring. And you also established Western Health COVID-19 Recovery Collaborative. That's amazing work. Thank you. And next one, how about David?
Hello, everyone. My name's David. I am a GP at the ME Research Clinic, but I also conduct some research. I'm a doctoral student at Melbourne Uni, and I'm conducting precision medicine techniques and trials in ME/CFS and long COVID. So trying to personalize and really target down into people. But I also wear 2 hats. I have a clinic and have a research, so a more in-depth understanding.
Thank you, David. It's so good to have you here. You're one of that rare spaces have combination of clinic practice and the research. That's amazing. Like Danny. Now, our last but not least is Jacob.
Hi all, lovely to be here today. I'm a research fellow on this long COVID project, but I come with kind of a broad interest in the design of technologies, later life, and particularly healthy aging. I was part of the first project that was looking at journey mapping studying people's experiences with long COVID, interviewing them and mapping out their experiences. So it's really nice to come back now and to be working with people like Natalie and Kate to be exploring kind of these long-term impacts on people with long COVID.
Thank you, Jacob. So you help complete the first Australian study looking into the journey mapping of people with lived experience. That was amazing work. Thank you. So we now have 3 questions for the panel, and we want to manage time well. Emma did a great job for the first hour. So we want to have no more than 15 minutes to discuss each question. And then at the end, we will have a Q&A session from the audience. So for the first question, so before we turn to long COVID specifically, I want to ask a broad reflection from you. What do we mean care? Not necessarily about just long COVID, just what do we mean care when we talk about care? How do you understand it and see it enacted in your work or everyday life? So maybe I should let Sam start. What do you think?
Thank you. You might regret that, but I'll try and keep it short and sweet.
Yes.
Because I feel like I have a lot to say, but I'll keep it focused. I think for me, I think what I perceived care as a nurse is very different to how I now perceive care as a sufferer of an illness, having always been very fit and strong and well prior to this. And I think for me, it's about having a presence, having a team, feeling validated and supported. And I think there may be a pressure on clinicians to feel like they need to have all the answers, but I wasn't necessarily after answers. I just wanted to feel heard and supported, and that people were on the journey with me, that I was being checked in on, you know, because it's an illness where it's so isolating. And I literally spent days, weeks and months in a silent, dark room, and you feel forgotten. And I think just having someone check in, you know, feeling like you were part of a healthcare team. And I very much felt like I was my own healthcare team. I didn't feel like I had an amazing GP, but she's restricted to her, you know, 10, 20 minutes of a consult. And that was definitely not enough for me. So that's probably where I would sit with care at the minute.
Yes, so it's about being validated and being listened to, right, and checked in. Yes, Sam mentioned about GP, so I might let David follow up from there.
Thank you very much. I echo Sam's thoughts on what we consider care, and I would almost try and provide exactly what Sam is describing there. So, and you have to remember that I have 2 roles, as I'm a GP, but I'm also probably considered like a terminal, like a specialist in this field. So as a GP, I'd say what our role is to provide a therapeutic alliance. So to try and build a relationship of trust and support where we can tackle the biopsychosocial aspects, so the social difficulties, the biological as much as we can, and then team building. So we're not going to have the answers, but we need to be the person who translates for the patient, who is there for those crash moments, for those difficult moments, and who can use multimodal deliveries to communicate. And that can take a variety of things. But care to me in this space as a GP and not as the terminal is more the alliance, the relationship, build it. And I agree that 10 to 20 minutes is a problem, and it's only going to get worse with the new models. But that is something that you and GPs, as long as you have the same GP, you can build that and you can move. You can schedule times, and that's something that I strongly encourage everyone to do.
Thank you. So building about trust and the partnership, that sounds amazing. How about Laura? You're representing Emerge, and you're doing consultation for people who suffer from MECF and CFS and long COVID. So you would have had a lot of experience about care from a very broad perspective.
Yeah, so the service that we have quite a few different patient-centred and care-centred spaces, but in reflection of it's more of a health and support call line rather than a telehealth clinical line. But when I pick up the phone and I meet someone, I'm really trying to meet that person where they are at that point in time. I have people who may have been sick a few days, a few months, a few years. I might be talking to a young person or an old person. The youngest person I've connected with is their parent, but the person impacted was actually only 11 years old. And then I have a 98-year-old person who says, I'm quite healthy. I've got my own house and garden. Then I got COVID. I'm really sick, and people just tell me I'm old. So there's such a big space within that, and people come with it with different teams around them. So for me, care is really hearing, listening, as Sam said, that validation piece of you are real. Your problems may look invisible on paper, but they're actually clinically not invisible. We hear you and see you, and what would the next step be? It doesn't have to be the whole picture. This is complex, multi-organs. It doesn't have to be the whole picture. As David said, it's what's that next step and how do we build that in 10 to 20 minute short snap appointments? And I think that's a really big question.
Indeed, I think I can see really how three of you converge on two important aspects. I might just go to Jacob next as a researcher in this area, in care aspect.
Yeah, it's been really nice to hear about care very much in that formal sense, to hear about that vocation, that work of people, that partnershiping with them. But in my own work, I often have to deal with care in very much an informal way, the way in which people might have come across it because of situations, circumstances. It becomes almost an everyday practice in the sense of the thing, in terms of how do you recognize when someone needs care? Do you have a willingness? Do you have an ability to deal with that person and support them in many ways? And so often when we're kind of thinking about, care and what I do, I think it's tricky because we look at what I've done in the past with older adults, and we get a sense for as we age, we develop this sort of network of people around us, our parents, we look after them, younger people, cousins, brothers, that sort of network forms. And the thing that we're really finding when we talk to people with long COVID and their carers as well is this, because of the suddenness of it, because of the unpredictability of who it impacts, is that people are going into this not really being prepared to be carers, not really wanting to be carers. It's a form of situation. And so then I think about those individuals and how we can better support them. How can we think about the ways in which people who are in unpredictable situations, financial hardship, those sorts of elements, how do we draw them in and recognize their work? Because what we find, and this is in the literature, is it can take nearly 5 years for someone to recognize themselves as a carer. It can take so long for people to actually get around the idea that, no, I'm not just the husband anymore or the wife. Actually, now this is going beyond what I thought my role was, and how do I reconcile that? And so, I think alongside thinking about the formal strands that we deal with these sorts of conditions, it's so important to really bring it back to who's the network and how are we supporting that network to care for someone as well.
Thank you. So you talked another part of this care ecology is the cares themselves, isn't it? The changing identity. Not only people who have lived experience have changed identity, but also people around them also changing identity as part of the process. Thank you. And Danny, your thoughts on care?
Yeah, I guess just building on what everyone else is saying, I guess coming from an OT point of view, I think, oftentimes care is thought about caring for symptoms and treating people, but we often hear from patients who work with occupational therapists, the symptoms are what my condition is, but the impact it has on my daily life is what it means. So I think care from my perspective as an OT is, caring for the person in terms of maximising them to do the things they want to do, have to do, need to do in everyday life. So it's a slightly different orientation. And of course, we all work together and offer our own bits of expertise. So I think that's my professional view, but I guess as a personal view, I don't have long COVID, but I live with disability. And I can tell you what care isn't. I remember going to see a doctor who had a mug on his desk that said, please don't mistake your, lived experience for my medical degree, in terms of, I know more than you. We didn't get along. So I think part of it is that you have to have, as a professional, and I have a foot in both camps, you have to have the humility to understand that, yes, you have expertise, that's why the person's coming to see you, but lived experience is also expertise and equally as valuable. I think if you're going to have a caring relationship with your patient and be compassionate and empathetic, you do need to recognise the limits of your own expertise as part of that. So that's what care is, along with what everyone else has said as well.
Thank you. You just bring another element about it, isn't it? You just talked about the opposite side of what poor care is, and it's that what written on that mark is so fundamental, so fundamental. That's what lived experience about. That's why we now focus on and value lived experience. Precisely. Thank you. I'm glad you brought that to opposite end of the care. Now let's move to the next one. Thank you for keep time really beautifully concise. Your answer concise. Our next question. Now we need to shift to care related to long COVID. So uncertainty is one of the most pressing challenges of long COVID. We don't have universally agreed upon definition of long COVID. Even WHO has one, but some people disagree. We're not clear in our diagnosis, and there are very limited effective treatments. So how are clinicians, people with lived experience, and advocacy organizations, or even carers, navigating this ambiguity, and what does it mean for how care and supports are delivered? So you have this challenge to to answer this question. So, and your experience. So I'd like to start this question with David, because as GP, you are really at the forefront of caring people with long COVID. You talked about your approach to care, but how do you deal with uncertainty and provide effective care when you're facing uncertainty? What are the main barriers at the system and the personal level?
So I think we have a few issues, and obviously that's a very big question that we could spend the whole month talking about.
Yes.
But navigating ambiguity can be helped a lot with, as Danielle said, the lived experience. And Laura, meet them where they are. Ask them what they want, because some people come to me, they want a diagnosis, and that's it. That's all they want. They're actually coping okay. Obviously, we have different understanding on what would be considered okay, but they are happy with their functional level. And others want treatments, and others want help with social things like getting on DSP or NDIS. Everyone wants something different. And also some people's expectations need to be managed. People want to get back to life like it was before. And I think it's heartbreaking when you hear that, when people are looking for a cure, because we don't have that. And we don't have effective treatments, but we could say the same about chronic pain, that we don't have effective treatments. And Zhenjiang, we know there are treatments. We don't know that it works for everyone, but different treatments work for different peoples. And I think just because the evidence isn't there yet doesn't mean it won't come soon. But I am optimistic, and I like to share that with people. Obviously we don't have much, but it's something. Big barriers, funding. Current block funding is going to be a problem for people with this condition, and the move towards bulk billed, very short consultations is going to be the hugest barrier we are seeing in our time for this condition, because you cannot articulate what you need to get done in 6 minutes. I've practiced 6-minute medicine before. Not only was it dangerous, but you had to split up one issue for a healthy person over 5 consultations. So if you could imagine this, you are not going to get anything. So that's a big barrier. I'll leave that open to the floor about what to do with that one. Thank you.
Right. Can I have a quick question about what you talked about short consultation? I thought in the national plan, actually long consultation is promoted and to do funded as well. So are we shifting to a long to short now?
Yes, most definitely. If you look at remuneration and the margins required in keeping a clinic open, I mean, I know from personal experience, I had a clinic that was mixed billing. So we bulk billed some and we private billed others, cross-subsidized, and we closed down trying to do that because we were bleeding hearts. And when you try to do long consultations, there is a diminishing return per block unit of time. So for funding per minute diminishes quite substantially once you hit 6 minutes. And there has been, not that anyone's aware of this, but there has been very substantial cuts on the 1st of November to different item numbers from Medicare. And while they talk about this increasing in time, they've actually cut co-billing items. And so that is the way we kept bulk billing clinics viable. And now they've moved that funding over to the incentives, and the incentives are only per single item. So you will notice it in the function and how the clinics will close down, or how the delivery of care changes. And I don't think people will like it, but we are, I guess they had to change something. I don't know, maybe. But yes, Jen, it's a bad situation. It is much worse than we know.
Indeed. Right. So now I'm a bit shocked. Now I need to move. We need to move this discussion, keep this discussion going. And anyone want to take up from there about barriers or dealing with uncertainties? Or
I think if you're happy for me to talk next,
yes, absolutely.
I talk to people, and I think the presentations today really sunk home with the lived experience that I'm hearing. Financial barriers. Most of, we looked at how many public versus private options there are out for people and the loss of work. How can you access anything if you don't have financial capacity? Also, knowledge within our general primary healthcare network. I still hear people that go to clinicians and they don't even believe that long COVID or ME/CFS is a thing, and people are just being dismissed. The other, I think, part of it is that there's a unique symptom called post-exertional malaise. And how do you explain to someone that, yeah, I had a shower on Saturday, I felt okay, but then on Monday I couldn't get out of bed? People look at you and think, that doesn't make sense. And it actually doesn't if you've never heard of it. So I have people who I will talk to and explain this pattern, and I will be able to share some tools and other conversations and some literature, and it's like a light bulb moment. So I think there's a huge piece on education in every single aspect, and I'm not going to name those because it could be here for forever. And then, as David said, it all comes down to money. I talk to people in my initial connection with them because, as I said, everyone comes with a different space and time and need, is 20 minutes. For some people, that's all they need, and I can send them off some information. They've got the literacy level to take that home and work on it and have the network in place. For others, I haven't even opened the doorway to what's actually part of their what do I need piece, and that's 20 minutes of a free call. I may then follow up with another 30 minutes, another 30 minutes, and then you start looking at NDIS and DSP, and the time required per person can be very extensive. And the last thing I'm going to finish on, because we're talking about what needs to happen, NDIS, for me as a person trying to give someone the health literacy to take back to a doctor to say this is my actual functional capacity due to post-exertional malaise and pull someone's medical history can take up to 10 hours of my personal time. I don't know what doctors have 10 hours per person just for one simple application, and they might put everything into it. It doesn't necessarily mean it's going to be approved, and in lots of cases it's not. And I will leave it there because I could keep talking about this issue.
Yes.
It's a huge passion of mine forever, and I can see everyone nodding in agreement.
Yeah. I might just move to Sam about how do you deal with uncertainty and the barriers you have experienced.
I honestly didn't cope. I think it was really interesting what Laura was saying about the post-exertional malaise and how we get people to understand that, or I have the disease, I have post-exertional malaise and I don't understand it. And I was very stubborn. I'd have these moments where I would feel well and I'd do something because I was so excited to have these moments of clarity and energy. And then that would put me back in bed for weeks on end. And I would always say, Emerge was probably the reason I'm still here. I'm an incredibly positive, optimistic person, but I was suicidal many times during the last 3 years. And I actually was just going back through my journal, which is hilarious because one of the coping strategies I was given by a psychologist was to journal, but the sentences are 2 or 3 words and it's all this. I couldn't write. I couldn't stay awake long enough to write down thoughts. So it's just very isolating. I think for me, the biggest shock was I thought, how can I be so sick that I cannot eat, I cannot get the glass of water to my lips, I cannot sit upright in bed, and yet I'm alone in my healthcare journey. And that was the biggest fear and the biggest scare for me was, I just don't understand. I think that was, really interesting when Danny was talking today in her, she was talking about the EQ SDSL scores and saying, it was similar to cancer. And then I think it was Natalie that was comparing, one of the people that she was quoting saying they wish they'd had cancer. And I often felt the same. I wish I had cancer because I understand that journey. I understand the disease process and we understand the pathway that will take. But I was so confused because I didn't understand the disease. And even now, it's just such a confusing disease to have. Give me something else. Give me something black and white that's tangible. This is just a nonsensical, ridiculous thing that, how can I be happy and smiling right now? And being in this conference could possibly put me back in bed for weeks on end. And people see me here in the conference and go, wow, look how well you are, look how good you are. But they don't see the weeks you spend in bed because I was here at this conference. So I think, yeah, for me, it's just been very confusing and very challenging time.
Thank you so much, Sam. Thank you for being so courageous and generous to share your experience. Yes, so if you feel a bit overwhelmed or tired, just take a rest. Yeah, so looks like the uncertainty still lingering around, isn't it? Hasn't been really cleared either. So thank you. Yes, Sam talked about Danny's talk and expertise, so I'm going to move that to Danny now to talk about this uncertainty, navigating.
I think there's a lot of uncertainty in the system. I mean, the Australian health system is not designed for people who have relapsing remitting conditions at all. You get into the system when you're unwell, if you can, and a lot of people with long COVID can't even get into the system in the first place. But if you then relapse quickly and you're out of the system because you've been well, you can't get back in again. It's just not designed for it. And because long COVID is so heterogeneous in its symptoms, you can have impacts on any body system, pretty much any symptom. Someone might be going to see a cardiologist for one thing and a pulmonary specialist for another and dermatologist for something else, and they don't talk to each other. So it's so fragmented. That's sort of, I guess, uncertainty that's been in the system for a long time, but long COVID really highlights that. There's obviously uncertainty around funding. It seems like things sometimes are flavour of the month and then they're not, and it's hard to get your head around that. But I think when we're working, one-to-one with someone with long COVID, something that does seem to help is taking a narrative approach. So seeing long COVID in the context of that person's entire life and how things were before, and acknowledging that things might be different now. And that can be quite useful in terms of trying to look at things like early warning signs that things are not going so well, trying to put some strategies in place. Self-management is massive for anyone with chronic conditions, but especially for people with long COVID, partly because they don't have access to the support they need, but also self-management is really affirming, and people can self-manage to some degree. Won't always work. Sometimes relapses happen for reasons none of us quite understand. But I think that's a really positive way of approaching the uncertainty, that you may not have full control over this, but here's some things you can do that may support you a bit better. So trying to take that more affirming, positive approach as much as you can, but not denying the fact that it is very unpredictable, and that has huge implications for how people live their lives going forward.
Thank you very much, Danny. So that's again acknowledged lived experience, isn't it? And the empowering people through self-management and education. Thank you. Jacob, how do you look into this uncertainty? And maybe I want to throw a question at you, maybe slightly different. Danny just talked about this self-management. And I also know there are some pushbacks about self-management, because sometimes people felt self-management become a excuse for health practitioners putting things back to patients. And did you come across that in your research and interviewing people?
Yeah, great question. It's nice to hear from the others and briefly probably reflect on the fact that a lot of the ambiguity we're hearing about is kind of because it meets this variety and variability in the symptoms and the treatments on offer. And I think we've definitely heard that through the research, is the way in which people are getting a hit and miss result. They're getting some things that work really well and some things that will floor them. And that's been really a reflection on kind of how the people actually navigate those expectations about getting proper treatment. To your question, and it comes back to self-management, is that it is a fine line. A lot of our earlier work around journey mapping was exploring and ultimately kind of came to some concepts around patient agency. And it's not a dirty word, but it is a careful word. And it's a word we need to use quite well, because a lot of that can be used to not only dismiss, but also put the burden on individuals and patients to do more of their work, to take on more of this stuff. But there is also opportunities where patient agency can see some greater results. It can see you actually seek out resources. It can see you actually take more control over your direction and perhaps improve your quality of life. And so I think when it comes to self-management, there are definitely some ways where it can be done well and the practices that people can learn and be supported to have. But it's also a thing where I think, and it's really important to hear about the financial challenges we're having systematically in the healthcare system, about where it's being used inappropriately as a way to maybe push the burden onto individuals for their own care and ultimately not address all the different facets of their life. People need to have that umbrella addressed. We've heard from people who have teams of, I think, 5 to 7 odd specialists that are managing them, that they've built over 3 to 5 years. It takes time, it takes work, and it's ultimately something that they're self-managing to some extent themselves, their own care coordination. And it's something that we don't pick up onto and isn't really acknowledged when it comes to the healthcare system. And so there's definitely things that when it comes to self-management, I always see it as a very thin line that we're walking here around patient agency.
Thank you. Thank you very much. I think we seem to agree the good care practice working well with long COVID, it is the trust building partnership validates people's experience, right? And in some way helping building agency, but not in a carefully managed way. Another question I want to have quickly your answer before we move to the closing reflection is, who are those particular groups you see most vulnerable to falling through the cracks in terms of this long COVID care and journey? Anyone?
I can start off if you like. I have very strong opinions on this.
Yes.
Going back to the WHO definition, I think one of the WHO definition was great, and that was the first sort of case description we had. So, it's not all bad. But because it really emphasised that all other, like if the symptom was due to another condition, then it couldn't be long COVID. That was very exclusive of people who had chronic conditions beforehand or people with disability. The NASM definition has kind of included
Yes.
those symptoms, that's much more helpful. But I think that led to a lot of people with disability and chronic conditions being excluded from care in the initial stages at least. Older folks, like someone mentioned before, just because you're old doesn't mean you're gonna, there is this thing called healthy aging that people don't get on. So a lot of older people, especially people living in aged care, and I guess in a group that's very dear to my heart are culturally and linguistically diverse communities. They face a lot of barriers getting care generally, but we haven't addressed the needs of those communities and understood their understandings of post-viral conditions. Long COVID isn't the only post-viral condition. And it's interesting when you talk to people about things like glandular fever, that people kind of go, oh yeah, my teenager had that or something, but this is more mysterious. So we have quite a few gaps in the community that we should be turning our attention to. And that doesn't mean they need special or unique models of care necessarily. Same model of care that's available for everyone should be accessible for anybody, essentially. So yeah.
Thank you. That's excellent. Anyone else want to add to this list?
Can I just add in there, I think talking about different people being able to access healthcare, we need to also talk about the extremes of long COVID, because you have the mild, the moderate and the extreme. And for those that are completely bedbound, they're not able to get to GP appointments. And there was several times I wasn't able to get to any appointments at all. And what concerns me the most is they're not being counted and tracked in any way, because unless you have a healthcare encounter, there's no coding. And even the coding we have isn't tracking. So I think a lot of the statistical information we're running off is, it's not really capturing the full picture either.
Yes, indeed.
If it's okay, I'll add to that. Because I think it's quite relevant, and I was going to go down the same track of severity. And severity has its own hidden disability. The more severe you are, the more you disappear from the medical service, and the harder it is to access. And most GPs, unless you've seen them face to face, will never offer a telehealth because they can't. So we have all of these barriers, and then accessing specialist care, there is a really unique, incredibly heartbreaking population of long COVID patients who are literally dwindling away in bed. When they go to hospital, they're actually dismissed and stigmatized with having things like anorexia. You don't eat because you don't want to. It's your fault. Let's put you into inappropriate care. These people then learn to fear healthcare, go home, get worse, and hide away. So I think that is, in my heart, these people are my heart sinks. These people I will remember by name for the rest of my life. And they're people who are most vulnerable because they can't get the help that they need, and some of them will die. So I just think that they're a really important population to acknowledge when we're talking about long COVID. And I think David will have some, heart patients as well that will travel with him for the rest of his life, as well as Danny.
Thank you for bringing this up. It's a bit traumatic, situation. So thank you for bringing up. And David, do you want to respond to that, or you were very much advocating?
I agree with everyone. I think it's been really difficult to try and access patients, to try and get out there. My reach for patients is over Australia, which makes things really difficult for me to try and see them, because either what happens is they will come all this way and then crash, and then I would argue, what's the point? Or we do telehealth without examination, and that's risky for both of us, missing something. This condition, the group of them are really difficult. I think country people are tough to access, and low socioeconomic. So people who just can't afford all of these treatments. I mean, all the treatments are off-label. Pacing is expensive. Everything just costs money. This is a really high first of all, just the income loss that's exposed to the family as well as the person themselves. This has a huge income issue, and I think that if we add healthcare costs into that, we get well over $10 billion, per year. Like, this is a massive cost. And a lot of that's shouldered by the person if they want help. And then if they can't afford it, that psychological effect of I'm not doing everything I could. So there's a lot. There's a lot of barriers. I would say for me it's location, but that's because I've had a week of tough location people. So everyone's like, there's very few people that don't have significant barriers to their care. In fact, that almost defines this illness in itself, is that the barriers are producing such deterioration that very few people present without any.
And I just, if I can just add to that, I think as well, it comes to a person's ability or their family's ability to research. Not everyone comes into this illness with the ability to research, and you have to self-advocate, and you have to be a very strong and powerful self-advocator to actually get the treatment and the help you need, just to be able to find out. Because the advice from my GP, which I have a good relationship with her and I have no qualms with what advice she gave, was go home and rest. But when you've been lying in bed for 6 months and you're not getting better, you're getting worse, but you're too sick to do the research. But I have those skills. I came with those skills, and I also came with great mental health toolkit. I knew how to keep myself mentally strong, and yet I still ended up in a very bad place on many occasions. So I think, there's like Jacob said, there's and David was saying, there's just so many barriers to getting well. And I truly believe the reason I'm sitting here now able to have these conversations is because I had the ability and the financial ability to get myself well. There's people that if they had my skill set and my support networks and my, when I say finances, I'm redrawing on my mortgage, but I had the ability to access money to get myself well.
Thank you, Sam. That's indeed another courageous moment. Thank you. I'm going to move to the closing reflection. I know Jacob has something want to say. He will say that in the closing reflection, because when you talk about agency, that's very close to Jacob's research. So the closing reflection, really, we want to imagine long COVID care futures. So now I invite you to envision the practical and future-oriented improvement. So for those listening today, and we would like the panelists to share one single most important insight or guidance you would offer about providing meaningful, effective care and support. So the first question is, I know it's going to be hard, but I want this one sentence from each of you. If you could shift one thing, policy, practice, or perception to improve care, what would it be? So I'd like any one of you to start. Danny, do you want to talk about that?
One sentence, my goodness. I would implement navigators, health system navigators. They're needed for a lot of people anyway. I think in Canada they have actually implemented it so that you have someone who's essentially doing the care coordination work that you won't have the time or the energy to do. That's what I would do.
Lovely, thank you. Jacob?
Such an easy question. I guess when it comes to this, and I'm going to draw on my own work because, again, I'm very much in that healthy aging and the aging space. And we're seeing a shift across Australia to an aging population across the world. And I think in general, as we we live longer, we have more conditions, more chronic conditions, there's a general need to shift from kind of the very acute short-term thinking and responses that we have, and recognizing that long-term care is needed for people with their GPs, developing these long-term relationships, doing things within the hospital beyond that respect and respond to the fact that we have trajectories in our lives that are complicated and we need to be supported through those now into the next decades. And turning up when you're at your worst is often not the best way to be proactive about these issues.
Thank you. Indeed. David, what's your one shift you want to make?
Can I just say, Jacob, I absolutely love that. I, my heart's just melted. I'm like, if I could have recorded that and put it on the wall, I would. This is it's very true.
Yeah, I'll just say I'm not really a good answer of that. I just went to the dentist recently, a little bit too late, and now I have to get a cavity filled. So we all make mistakes.
We do, but I think that is the point. And I think with chronic illnesses, we have an opportunity to schedule appointments in different delivery modes in ways that you're not going in with a problem. You're going in with, look, this is who I am. Let's focus on optimizing something instead of I'm in a bad way, I can't do anything. But on this question of one meaningful thing I might really try to leave people with, it's building the team of trusted professionals that you like, that you've got the alliance with. And if you don't like someone, that's a barrier to your care, find someone else. No one gets offended if you change. No one, I mean, sometimes a little bit, but it's not your responsibility. And I want people to build the team with people they feel they're trusted, and go and see them, and keep engaged as best you can, because honestly sometimes the funding is a mess. But build your team and see them, just like Jacob said. My God, I loved it. I'm going to be thinking about it for months, I think.
Jacob's paper about the agency and the support, right?
Yeah, I'm going to read it now. I'm going to go and look it up.
How about Sam? What would be the one thing you would like to change, the shift, if you're the Prime Minister or Health Minister?
Can I have two? I really want to have
You're
two.
allowed to have two.
So my number one would be, we need to track the numbers. We need to get better statistics, because with showing the real true numbers, there comes a lot of power, and with that becomes funding, and then becomes solution. So that would be my number one thing, but it's a very difficult, challenging. So anyone wants to take that on board, we need to figure out a way to track this better. My number two, I really would be interested to see if we can emulate the McGrath Foundation model of care. And somehow, and I don't know how it works behind the scenes, but when people are diagnosed with breast cancer, within a day or two of that diagnosis, they have a McGrath Foundation nurse visit them in their home. And how fabulous would that have been to get some IV fluids and some nutrition in those first weeks when I was completely bedbound and just dehydrating away in bed? So they would be my two wishes, I guess.
Yes, that's really good. It's come to what Danny talked about, early intervention. Yes, thank you. Laura, now you were speaking for Emerge as well.
Emerge. Yeah. And I think I would like to speak from the community that I hear from. Biggest barrier to accessing care. There are, as David's pointed out, a couple of really helpful medications that help some people. The cost of those is huge. Research to make them eligible for any kind of funding that every GP has their toolbox lacks. So we need that funding in research. We need it into making these treatment guidelines available for every single GP. And they need to be a living guideline that doesn't just sit stagnant, because research is coming. And for the patients that are out there, I've been in the ME/CFS space for a really long time, and the last 10 years has been huge for this space. And long COVID has definitely boosted that. But we need money. We need research into really good treatment. No one should ever not be allowed to access very simple medications because they can't afford it, or their GPs don't have confidence behind them that they won't lose their registration if they prescribe it.
Thank you. Thank you. Right. The next question, it's about what's the next step going from here now? I think you kind of touch on that, isn't it?
Money.
Money. Yeah, you all agree? Money.
And activism. We have to sort
Yes.
of get out there and walk the walk and actually be, activism is, and, advocacy is what gets you more money, hopefully, along with
Yeah.
research and all of the other good things as well.
Yes. Be the crime baby. Sorry, Laura, I interrupt you.
No, I think I was just going to leave it
Oh.
really simple. We need government to care.
Yes.
Rather than withdrawing, we need them to jump straight back in where they were a couple of years ago and keep the momentum up and not lose focus on what actually matters. And I don't know what numbers we're quoting for long COVID patients, but I think it was around, 500,000, 700,000, and I don't actually think that that's even close to the real accurate number.
Right. Final question. So what peer support and community-based initiative play alongside clinical services?
I'm so sorry, Chen. I might just
Oh,
jump
we
in
need
at this point
stop
just
right.
because
Sure.
I know we've got so many juicy things to talk
I
about.
know.
But I just want to
Yes.
make sure, because we're
We
gonna
have
Kate,
questions.
who hasn't been with us yet, but she's gonna close for today, and I just want to make sure she's got
Lovely.
enough time. Just to note, we've had some questions come in that we won't be able to
Sure.
get to today, but what we'll do
Okay,
is we'll
great.
definitely follow up with everyone afterwards.
Yeah.
So I guess I just wanted to say this was an amazing discussion, and thanks to everyone for sharing your insights and experience, and Chen for doing a great job moderating. It's and everyone that's been with us today, thank you. But I might hand over to Kate now and just introduce Kate, who's going to be doing a bit of a closeout for us. So Kate's a really important part of our LAMP project. We haven't seen her yet, but she's leading the qualitative side and has been sort of instrumental in pulling it together. So Kate, if you're there, just wanting to hand over to you to close out and offer some final reflections. And thanks again to everyone today for joining us, and for everyone that's been presenting and talking and sharing their experiences. Thank you.
Yes, can you hear me okay, everyone? Hopefully you can.
Yes.
As a qualitative researcher, I couldn't help myself. I've been sitting today doing a kind of rapid synthesis of all of the themes that have come up. So I hope I do it justice in this short closing. Today's discussions have shown how wide the ecology of long COVID really is. While this symposium centered on a single condition, what we've actually traced today is an interconnected web of bodies, systems, labour, policy, and relationships. Danny's economic perspective reminded us that long COVID isn't just a biomedical challenge, it's a systems level disruptor. Long COVID increases demand on the health system, it reduces workforce capacity, and it erodes well-being. That triple burden ripples outwards. Billions are lost in productivity. National GDP losses are on par with major chronic diseases, and healthcare costs are 40% higher for people living with long COVID. But behind those economic numbers are people quietly choosing between a medical appointment and groceries. People losing not only their health, but their stability, identity, and the scaffolding of everyday life. Danny reminds us that investing in long COVID is not just a matter of equity, but also foundational to Australia's economic recovery. Nat's presentation brought us into the homes of people with long COVID and their carers, often invisible spaces where complex care takes place. Our interviews with carers have revealed an intensity of care that many of us recognise viscerally. Carers sleeping fully dressed with their phones on their chest, young adults needing support they never imagined requiring, and family members carrying emotional labour, physical tasks, financial strain, and advocacy all at once. Ultimately, people are navigating care inside a carescape that's not built to hold them, and many are falling through the gaps. Today's presentations and panel also peeled back the clinical layer of the care ecology. Rose showed that even as clinical guidelines are evolving, the carescape that Australians with long COVID enter is increasingly fragmented. Specialist long COVID clinics have mostly been absorbed into general primary care and allied health, increasing economic and logistic barriers to care. Sonia described patients who had been dismissed and misjudged by healthcare professionals or treated as hypochondriacs. Our panel clinicians describe the challenge of integrating an emerging and complex evidence base into time-limited general practice, especially, as David noted, in regional or low-resourced communities. Everyone emphasised the need to value lived expertise in care. Meanwhile, Sam and Jacob shared the challenge of being positioned as a primary interventionist or expert for one's own disease. Overall, these tensions paint a picture of care that is available on paper, but frequently exhausting or practically out of reach. Our presenters leave us with several provocations. Firstly, how can we build scientific literacy, humility, validation, and communication as core competencies in long COVID care? Secondly, how might we better utilise the enormous volume of lived experience, knowledge, and emerging scientific evidence with the assistance of digital tools and better system integration? And finally, how can we balance the need to empower and centre lived experience with the immense workload of advocacy and self-management for people living with this condition? Looking ahead, these considerations will shape the next phase of our own program. So we're preparing to launch a national survey of long COVID impact to map the depth and breadth of this condition across Australia. We'll also be exploring the experience of service providers, including those informal providers who support people in ways our systems rarely recognise. And we're committed to targeted, culturally grounded explorations with children, culturally and linguistic diverse communities, and also with First Nations communities, not as add-ons, but as essential to understanding the full ecology of long COVID care in Australia. And if you're interested in any of or all of those projects, we'll be sharing some links to them after the symposium. Across everything we've heard today, economic, clinical, relational, experiential, a single pattern emerges. Long COVID isn't one problem, it's an ecology of problems wrapped around an ecology of care. Every part of that brings costs, but also possibilities. Today's presentations invite us to build a carescape that sees the labour of carers, integrate clinical pathways, and removes financial impossibilities, and treats long COVID not as an edge case, but as part of the ongoing fabric of chronic illness in our society. For me personally, today highlights how we're already caring for one another in our families, communities, clinics, and research teams. The question for all of us now is how we design, fund, and sustain an ecology of care that can hold the weight of this condition without leaving individuals to carry it alone. So thanks for attending today, and we look forward to continuing this conversation with you. Thanks, Emma.